And this is our last screencast for week number 1. We're looking at chapter 6, the psychological adaptation to chronic illness and disability. So this is a primer. Some statistics. Approximately 54 million Americans, so about 1 in 5, have physical, sensory, psychiatric, or cognitive disabilities that interfere with activities of daily living. More than 9 million Americans with disabilities are unable to work or attend school. $60 billion are spent on the U.S. government to assist people with disabilities. 8 out of 10 of the most common causes of death in the U.S. are associated with chronic illness. So from this chapter, review the process of psychosocial adaptation to chronic illness and disability. Present methods commonly used to assess psychosocial adaptation to chronic illness and disability, and explore intervention strategies applied to people with chronic illness and disability. The onset of chronic illness and disability associated with the disease process, for example, multiple sclerosis or cancer, or a traumatic injury. And let me rephrase that again. I left out a key word there, the onset of chronic illness and disability. And I'll just add it is typically, that's kind of important, associated with a disease process like MS or cancer, or a traumatic injury like a spinal cord injury or a traumatic brain injury. Chronic illness and disability is also dichotomized into congenital, or evident at birth, or adventitious, or acquired later in life, such as Parkinson's disease or an amputation. The literature related to psychosocial adaptation to chronic illness and disability is grouped into 3 headings: basic concepts, chronic illness and disability triggered reactions, and chronic illness and disability related coping strategies. The concepts of stress, crises, loss and grief, body image, self-concept, stigma, uncertainty and unpredictability, and quality of life fall under the basic concepts category. So looking at stress, individuals with CID have an increase in both frequency and severity of stress. Stress can be related to threats to one's life and well-being, body integrity, independence and autonomy, challenges to fulfillment and roles, future plans and goals, and economic challenges. Crises, so the sudden onset of medical impairments and disabilities, and that of life-threatening diagnoses or loss of valued functions, is highly traumatic. As such, these conditions constitute a psychosocial crisis in one's life. Crises, by definition, is time limited. During its presence, life is affected by disturbed psychological, behavioral, and social equilibrium. The psychological consequences of crises are long-lasting and may even evolve into pathological conditions such as post-traumatic stress disorder. Loss and grief. There is a mourning process due to the loss associated with chronic illness and disability. What did one have? What is one missing that they always used to like to do? Loss of work, loss of social connections, interactions. Body image. So the body image being the unconscious mental representation, a schema of one's own body. There is an altering or distortion of one's body image after CID. One's self-concept and self-identity are linked to body image and are often seen as conscious social derivatives of it. Self-concept and self-identity may be discordant for many individuals with visible disabilities. The sense of self, in other words, self-identity, which is privately owned and outwardly presented, may be denied in social interactions with others who respond to the person as quote unquote disabled first, thereby losing sense of the person's real self, the person's self-esteem, representing the evaluative component of the self-concept, gradually shows signs of erosion and negative self-perceptions following such encounters. Stigma. There is an impact of stereotypes or prejudice towards people with CID. Uncertainty and unpredictability. Some disease processes are stable or predictable, others are not. And then just imagine or appreciate the stress that's associated with that unpredictability. How do you plan for the future? Can you plan for the future? Is one day different from the next? Quality of life. The ultimate psychosocial outcome in rehabilitation practice is believed to be that of post-CID quality of life. As a global and multifaceted construct, quality of life includes functional domains that are of interpersonal, extrapersonal. How is one's quality of life impacted to affect one's perceptions of life satisfaction and feelings of well-being, the intrapersonal? How it impacts their interpersonal or their family life and social activities, or how it affects the extrapersonal, those work activities and their housing. CID triggered responses, the most frequently experienced psychosocial reactions are these: shock. Short-lived reaction marks the initial experience followed by the onset of a traumatic and sudden injury or the diagnosis of a life-threatening or chronic and debilitating disease. The reaction is characterized by psychotic numbness, cognitive disorganization, and dramatically decreased or disrupted mobility and speech. Anxiety. Reaction characterized by panic-like feature on initial sensing of the nature and magnitude of the traumatic event. Denial, regarded as a defense mechanism to ward off anxiety and other threatening emotions, involves the minimization and even complete negation of the chronicity, extent, and future implications associated with the condition. Depression. This is commonly observed in individuals with CID. Is considered to reflect the realization of the permanency, the magnitude, and future implications associated with the loss of body integrity, chronicity of condition, and impending death. Feelings of despair, helplessness, hopelessness, isolation, and distress frequently reported during depression. Anger, hostility. Frequently, this is experienced by individuals. One may experience internalized, kind of self-directed feelings of behavior or resentment or bitterness or guilt, and there may be externalized, directing those towards others. Adjustment in this reaction, also referred to as reorganization, reintegration, or reorientation, it comprises an earlier cognitive reconciliation of the condition, its impact and its chronic or permanent nature, an effective acceptance or internalization, and an active pursuit of personal, social, and or vocational goals. Now looking at CID-associated coping strategies, coping is a psychological strategy mobilized to decrease, modify, or diffuse the impact of stress-generating life events. There is the disengagement coping strategy and the engagement coping strategy. Disengagement coping strategies. These strategies refer to coping efforts that seek to deal with stressful events through passive, indirect, even avoidance-oriented activities such as denial, wish-fulfilling fantasy, self and other blame, and resorting to substance abuse. These strategies are often associated with higher levels of psychological distress, difficulties in accepting one's condition, and generally poor adaptation to chronic illness and disability. Engagement coping strategies. These strategies refer to coping efforts that diffuse stressful situations through active, direct, and goal-oriented activities, such as info seeking, problem solving, planning, and seeking social support. This strategy is linked to higher levels of well-being, acceptance of the condition, and successful adaptation to CID. A number of measures of psychological adaptation to and coping with CID have been reported in the literature. So in this following section, we're going to look at some of these utilized outcome measures. These measures may be things of interest to you to use for any patient that you might be working with, or these may be of interest to you if you plan on going on to doing any research with individuals with chronic illness and disability. The MILLON, not million, let me drop this other I here, MILLON Behavioral Health Inventory, the MBHI. It is a 150-item self-report questionnaire organized into 20 clinical scales. Scales classified into 4 domains: coping styles, psychogenic attitudes, psychosomatic complaints, and prognostic index. This inventory seeks to describe psychological styles of medical service recipients, examine the impact of emotional and motivational needs and coping strategies on disease course, suggest a comprehensive treatment plan to decrease the impact of deleterious psychological reactions. Strengths of it include sound psychometric properties, clinical usefulness, applicability to a wide range of medical and rehabilitation settings. Weaknesses: empirically unconfirmed domain structure and potentially reactivity influences and response bias. The Psychosocial Adjustment to Illness Scale. This is a 46-item instrument designed to measure psychosocial adaptation to medical illnesses and chronic diseases. There are 7 subscales. Strengths of it include its psychometric robustness, having both self-report and clinical interview forms, availability of normative scores for several medical conditions. Weaknesses are a lack of data on possible response bias influences. The Acceptance of Disability Scale. This is a 50-item 6-point summated rating scale. It's designed to measure the degree of acceptance of disability. Items are summed to yield a single score representing changes in one's value system. Strengths: they are a theory-driven rationale. There's reliability. Use in a large number of English-speaking and non-English speaking countries. Weaknesses: lack of investigation of its factorial structure, its unidimensional approach to complex constructs, lack of data on response bias influences. The Sickness Impact Scale. This has 136 items. There are 12 subscales. Strengths include comprehensive and rigorous psychometric development and properties, extensive use with patients diagnosed with a variety of physical and health conditions, and its availability for individuals who speak Spanish. Weaknesses: it's yet to be tested factorial structure and susceptibility to defensiveness and response set. The Reactions to Impairment and Disability Inventory. 60-item scale intended to investigate 8 clinically reported classes of psychosocial reactions to the onset of CID: shock, anxiety, denial, depression, internalized anger, externalized hostility, acknowledgement, and adjustment. Strengths: comprehensive psychometric development, scale reliability, multidimensional perspective on adaptation to CID. Weaknesses: there's scant concurrent validity data, lack of normative data across disabling conditions, and potentially confounding effects of response bias influences. Now, looking at intervention strategies. Numerous theory-driven, reaction-specific, and clinically documented intervention strategies to assist people with CID successfully adapt to their conditions have been reported in the literature. So the book then reviews some major approaches to psychosocial interventions applied to people with CID. There is the theory-driven intervention. This focuses on clinical applications of widely recognized personality theories and therapeutic models to persons with CID and the perceived merits of their use. These include psychoanalytic, individual or Adlerian, Gestalt, rational emotive behavioral, cognitive, and behaviorist. Looking at the psychosocial reaction-specific interventions, these eclectic interventions aim at offering a logical match between specific psychotherapeutic strategies and those reactions evoked during the process of adaptation to CID. Counselors seek to link specific counseling strategies with clinically observed or client-supported psychosocial reactions. There's the global clinical interventions. These are geared toward assisting people with specific CID in successfully adapting to their condition and its impact on their lives. These interventions provide the client and his or her family with emotional, cognitive, and behavioral support. These interventions equip the client with adaptive coping skills that could be successfully adopted when facing stressful life events and crisis situations. So, what does this mean for you, this chapter? Now, this chapter, again, it was labeled or titled Psychological Adaptation to Chronic Illness and Disability, a primer, but I left off at the beginning for counselors. So, what does this mean for you if you're not a counselor? Now, most people that go through these programs are not a counselor or psychological professional. You're probably a PT or OT. That is the primary population of individuals that take these courses. You may be something else, but if you're not a counselor or psychologist, what good is this information? Well, it helps you with recognizing behaviors, recognizing that people go through a grieving process, that they're going to have denial, anxiety, depression. Where are they when they begin working with you? Recognizing that there are coping strategies, different models that are recognized. What are they doing that's healthy? What are they doing that's unhealthy? Again, that may not be something that you do. Now, I know occupational therapists are more involved in the psychological side of things at times. Physical therapists, we try to support individuals. We try to, through our physical activity and our interactions, have a positive impact, but we're not psychological professionals. So we may need to refer people to psychology services. And also, if you're interested for the clinical side of things, for research, those tools listed earlier may be things that can help you if you're interested in the psychological response to chronic illness and disease and the impact that it's having on people.